Good evening and welcome to this evening's lecture of distinction from the British Orthopaedic Foot and Ankle Society. It gives me great pleasure to introduce your speaker for tonight, Miss Anna Chapman. She is a consultant in Coventry and has been a member of the British Foot and Ankle Society Education Committee since 2015. She is a substantive foot and ankle consultant specializing in conditions, particularly around arthritis, that we're going to hear about tonight. She is a strong educationalist. She's been the program director for Warwick SPR Registrar Training Program for the last year. And it gives me great pleasure really to introduce her to tonight's lecture in the webinar series on the hindfoot and midfoot arthritis. Thank you very much, Anna.
Okay, good. Right, good evening. So BOFAS team, can you see?
Yeah, we can hear you and see your slide well.
Yeah, and forgive me, it's just, give me 2 seconds. It's just, sorry, it's just randomly gone to the end. Apologies, everybody. IT, there we go. Okay. Okay. All right, well, there we go. Slightly inelegant, but we've done it. Okay, all good?
Fantastic.
Just slides, sorry guys, thanks for that. Okay, so good evening and thank you for joining this webinar late on a school night. I hope to cover what you need to know about midfoot and hindfoot arthritis, both for the exam and then also if you wish to be a foot and ankle surgeon. So I'm gonna start with the midfoot to begin with, and then we'll move on to the hindfoot. And I will go ahead and advance my slides now so that you could basically see the objectives for the talk. So we are firstly going to talk about the midfoot and hindfoot anatomy and biomechanics, which are relevant to arthritis, why it occurs, and the treatment of arthritis. It's important when you're assessing patients to understand what symptoms they present with and how we're going to diagnose and treat problems in the midfoot and the hindfoot, because it can be quite confusing sometimes to figure out what treatment patients actually need and how best to execute that plan. Finally, we're going to talk about the principles of arthrodesis and review foot and ankle fusions. I think it's really important to spend some time talking about the principles of arthrodesis purely because it applies to all subspecialties in orthopedics, and I want to take the time to do that in this talk because, let's face it, treatment of the midfoot and the hindfoot is really about arthrodesis. Okay, so right, so we've talked about the fact that we are going to revise the relevant foot anatomy and biomechanics, and the key learning point from this is really to understand the different regions of the foot, the joints within them, and the biomechanics relevant to this problem. I want you to be able to take away learning and understanding about how to diagnose and pinpoint which joints need treatment in midfoot and hindfoot arthritis, and then understand the different types of fusion. So yeah, you can describe a fusion by the anatomic location, but there's different types of fusion which we'll go through and how they fit into your treatment plan, because foot and ankle isn't really about just having one operation and this is saying this is what you do for a given problem. It's about having a whole kind of range of tools in your toolbox, and you choose what you need to do for each patient, and you fit your treatment plan based exactly on what that patient needs and what their deformity or pain or problem is. And then I want you to be really comfortable with the principles of arthrodesis, so if you have to fuse a joint, you know what you're aiming to achieve. So regions of the foot include the forefoot, the midfoot, and the hindfoot. So the midfoot includes the tarsometatarsal joints 1 through 5, which we know as the Lisfranc joints. And importantly, the midfoot also includes the navicular cuneiform joints, which articulate with the medial the medial, middle, and lateral navicular cuneiform joints there on that medial side. The hindfoot is essentially known as the triple joint. So you have the subtalar joint, and then you also have the transverse tarsal joint, which is described in older books as the Chopard joint, which includes the talonavicular and the calcaneocuboid joint. So again, with the anatomy of the midfoot, we can talk about the different regions, but then we also talk about the columns of the midfoot. And the medial column basically includes the first tarsometatarsal joint and the medial sorry, forgive me, it includes the first TMT joint. The middle one includes the second and third tarsometatarsal joints and the intercuneiforms. And the lateral column includes the fourth and fifth tarsometatarsal joints, which are very mobile relative to the fixed midfoot. The three cuneiform joints, as you can see in the picture here, we always talk about this in relation to Lisfranc injuries. The three cuneiform bones and joints form this Roman arch, and the second is the keystone. And that essentially leads to inherent stability within the midfoot. And it's key to the function and stability of that midfoot, which we'll talk about in a minute when we go into biomechanics. So the midfoot is important because it's a very stable aspect of the foot, and it acts as a beam and it provides stability and translates the forward propulsion motion of the hindfoot to the forefoot from heel rise to toe off. The second and third tarsometatarsal joint gets the majority of the force through the midfoot, and unsurprisingly, it's the most common area to get arthritis within the midfoot. The more mobile TMT joints laterally contribute to the ability of the foot to accommodate to uneven ground, and they are definitely much more mobile. So moving on to midfoot arthritis. So you can see in this picture here, it's just a close-up. You have a patient there who has some second and third tarsometatarsal joint arthritis, and it's a very common problem that you see in clinic. So I would say that we see a lot of patients who have pain in their midfoot, and it can cause significant pain and disability. What's interesting is I think you spend a lot of time injecting patients for this problem and treating them with insoles, but you don't come to many fusions relative to the number of injections you've been doing. So it's something that we see a lot, but we don't operate and fuse all the people who come through with that problem. So it can often be managed with insoles and injection, which we'll talk about in a minute, but it is a really common problem that presents through your clinics. So it causes difficulty mainly due to pain, but also it can cause difficulty with shoe wearing due to the deformity that can occur. We'll talk about that in a minute and why that occurs. And it can also cause difficulty with shoe wearing due to the osteophytes embossing, which occur due to the arthritis in those midfoot joints. And it can cause quite painful bumps on the top of the foot, which can be painful with weight bearing and shoe wearing. Midfoot OA, as we've said, is most common in that middle, second and third TMT joint. And you see two spectrums of disease with midfoot arthritis. And you see patients who are older in their 60s who may well just have degenerative arthritis or inflammatory arthritis, and they can have very extensive disease and it can be very deformed. You also see the group of people that may have post-traumatic arthritis, and it's from usually some sort of Lisfranc injury. And what's interesting is it may not be a big Lisfranc injury that was identified at the time that had fixation and all those sorts of things, but it could be just a very subtle injury that maybe they didn't get full collapse of their Lisfranc joint, but they did get a little bit of diastasis, and that over time, that slight displacement has led them to have arthritis. So you really do have that, the two spectrum there. So if you see it in a younger patient, be thinking maybe what kind of injury they had. The other thing that's important to remember with midfoot arthritis is that one of the key places that Charcot arthropathy presents in neuropathic patients is in the midfoot. So you might see someone who has a very mild history of injury, they're diabetic, they're known to be neuropathic, and they can have disruption in the midfoot. So just always be thinking about that in and how they present and when they get to your clinic. So when arthritis develops and you get the subchondral sclerosis, you get osteophytes, you get that swelling around the joints, and the degenerative processes around the joint basically stretch those intercuneiform joints and the tarsometatarsal joints. And that causes big disruption of those complex architectural articulations within the joint. And with time, weight bearing through that longitudinal arch, the stress on those slightly deformed joints will eventually lead to a pes planus type deformity. And that won't be related to like a tib post dysfunction that we often associate pes planus to. It will be due to that disruption of the joints, the ligaments, and the stresses through the joint. And so when you think about a deformity in a midfoot arthritis, you can basically ask yourself, do I think this was a midfoot arthritis that has caused this deformity and that's the problem? Or is it someone who's maybe had a tib post dysfunction for many years, they've had a deformity in their foot and now they're getting arthritic there? At the end of the day, your treatment may or well be the same, but it's just interesting to ask yourself what you think the problem is. Over time, the altered biomechanics, you basically, I have some pictures coming up here, you get progressive pronation of the foot, you get some dorsiflexion and you get a midfoot break, and then you get an abduction deformity of the midfoot. So you're getting a very deformed foot that can be very uncomfortable to walk on, and then you may get compensatory hindfoot deformity to accommodate this. So this was a gentleman, this picture was many years ago, it was right when I was a new consultant, and he had been in Thailand or abroad somewhere else and had injured his foot, and he had a Lisfranc injury that had been missed. And basically within a period of 3 or 4 months, he basically had that deformity where he started developing that pronation and abduction. And you can see here, he's got a nice arch here. I'm sorry, they're not the best photographs in the world, but I'll always remember him. That he's got that arch there, and here that arch is flattened, and he's beginning to get that abduction deformity there. Patients like this present with pain, with loading in the region of the TMT joints. It's a deep aching pain like a toothache, and they get a lot of pain with walking upstairs. And we talked about the bossing of the TMT joint that can occur. So clinically, you're looking for that deformity, you're palpating, so we talk about look, feel, move. And the key thing with the tarsometatarsal joints is that you want to be able to easily identify the joint with your finger. So it's digital palpation on each joint. So it's worth doing some surface anatomy. You can use your own feet. And basically you walk down the metatarsal till you get to the joint. And you always want to remember that the second is recessed and it's much more lateral than you think, and it will be more proximal. And basically you can get really good at just palpating each joint, 1, 2, 3, 4, 5 across to see if that's where there's pain. And you get really good at it, and you can literally put your thumb on it and say, oh, that's where it hurts. And that helps you diagnose the pain. And I cannot stress how important it is in midfoot, hindfoot arthritis, particularly the midfoot, to be able to palpate those joints, because it will help guide your clinical assessment, what joints need treatment, and help you plan your injection treatment and then your fusion. Because patients, I had one today on my theater list who came in and he's like, I've got pain all over my foot. And you're like, I know you have pain all over your foot, but I need you to tell me which bit really hurts. So it's worth learning that, particularly down into the navicular cuneiforms as well. The movements of the TMT joints are fairly limited. There isn't a big range of motion. The first is probably the most mobile, but again, you can do like a pronation, abduction, rotation when you're doing clinical examination, but ultimately it's really that palpation that gives you the information. And you should also always look for a tight gastroc, TA, do a silver scale test on the patient, because that might be need addressing when you do your correction. So imaging, after you've seen them in clinic, you want to always get AP and lateral weight bearing films. An oblique can sometimes be helpful as well in this situation, which is non-weight bearing. And you're looking for the classic signs of degeneration within the midfoot. You can see the osteophytes. You can look for the midfoot break, whether it's at the talonavicular joint or the navicular cuneiform if they have a pes planus type deformity. And CT and MRI can be useful. In a lot of the books you read, people will say that it's not necessary, but it can sometimes be helpful to just maybe determine the extent of arthritis if you're unsure from your clinical assessment and your injection treatment. So you can use that on a as needed basis to help further delineate, but CT is very helpful if you're looking at which multiple joints are affected. So conservative treatment for midfoot arthritis, it's always going to be the classic things in orthopedics: activity modification, analgesia. Specifically in the foot, you can refer to orthotics for softer, rigid, custom molded orthosis, supports the medial arch. Rocker bottomed footwear can be a really easy way that patients can help themselves. Basically anything in the shoe that decreases motion will decrease pain, and so that can really help. Once they've exhausted conservative treatment, to help you plan, well, to hopefully give them some symptom relief, but also to plan future surgery, you can consider doing targeted injection. This is done in theater with an image intensifier, and it's hopefully diagnostic and therapeutic, and it's really important to explain to them the importance of the pain diary so that they can write down how much of their pain was relieved at specific intervals, because that local anesthetic injection within the joint, even on the day of the injection, if it gives them good pain relief, it can really help them, really help you figure out where their pain is and give you some information about how you want to plan your surgery. So it's really a combined approach, basically using your clinical examination to see which joints are painful, using your imaging to see if that correlates, and then you can do the steroid injection in theater and identify the joint. So this one here is a second tarsometatarsal joint. And what you have to be aware of is that although this is really good in terms of being fairly specific, the dye can sometimes leak throughout the midfoot, and you can see a little bit of tracking here. So you just need to be mindful, and it's worth documenting in your operation note where the dye tracks. So if there's any debate, you can correlate that with their clinical picture and their imaging and how you decide on your fusion, okay? So just be aware of that, but generally on the whole, it works quite well. So surgical treatment for midfoot arthritis is really only if all of the conservative treatments fail. So when we talk about midfoot arthritis, really, we don't have any replacements that we can do. It's really all about fusion. So it's worth talking about the different types of fusion that can be done. And essentially you have two big ones. So you have an in situ fusion, and this applies to all of foot and ankle, an in situ fusion where you have easy positioning because there's no deformity and you're literally fusing arthritic joints in the position they are. Very occasionally, you might need to do an in situ fusion and do a corrective osteotomy, say of the heel, to help align the foot shape. I wouldn't worry about that too much right now because that's more for complex deformity correction, but just to let you know, you can use those in combination for bigger deformities. The other type of fusion, which you may need to use in the midfoot, is a deformity correcting fusion. And that's basically where you make cuts in the bones to help correct your deformity when you fuse it. And essentially the surgeon has to decide on the alignment of the fusion. So that gets a bit more complex, and you just need to be thinking about how you're going to correct the foot and whether it would be an in situ fusion or a deformity correcting fusion. So a good example of a deformity correcting fusion, a nice straightforward one, is basically the Lapidus fusion. So that's when you get a hallux valgus and you want to correct proximally at the first TMT joint because they have arthritis or they have instability. And essentially what you're doing is a lateral based closing wedge. So when you make your cuts for the fusion, you're taking out more bone laterally so that when you close the fusion down, you're bringing that first ray back over to the lateral side of the foot. So it's a fusion and you're correcting a deformity with it. So that's just a really straightforward example. And you can also correct it in the sagittal plane here, where you're taking more out from the bottom. So this is actually a really good point here to talk about too, that when you're doing midfoot fusions, you have to remember how deep the bones are in that midfoot. So they're a good 20 to 22 millimeters, sometimes a bit longer. And you have to be very careful to get down to the bottom of the joint and clear the bottom of the joint here, because one of the big potential pitfalls of doing a first TMT fusion or Lapidus procedure is that if you don't clear the bottom of the joint here and you've left bone at the bottom, you'll essentially elevate the first ray, and that can make the patient's problem worse because they can get lateral transfer metatarsalgia and pain. So throughout the midfoot, you need to be extremely conscious of getting down to the bottom of that joint and clearing the joints as needed. So principles of arthrodesis. So essentially, we're just going to take a step away from the midfoot for a second and just talk about arthrodesis in general. So arthrodesis enables a surgeon to create a painless, plantigrade, stable foot. And essentially you want to improve pain and function, but the problem with fusions and why you have to be a bit careful about doing them is that the fusion, because they're rigid, places increased stress on the surrounding joints. And that can lead to arthritis in the joints over time, and it can lead to pain. So as a general principle, you want to avoid arthrodesis in younger patients who are less than 50. It's not to say that we don't ever do it, but again, you just want to be mindful and manage people conservatively as you can. Obviously, general principles with all the orthopedic pathology, you want to assess the skin, the neurovascular status. Essentially, the first thing I do with these patients is always check their pulses, because if they don't have pulses, you're not going to be offering them a fusion. Smoking is super important. It's important to know if they're currently smoking, and it can be worth counseling them on stopping smoking before you even maybe put them on the waiting list for the fusion, or if they can't stop smoking and you have to proceed with the fusion, the patients need to understand that the risk of a non-union with smoking is much higher than if they don't smoke. So it really is in their interest to stop smoking to help give them the most optimal outcome for their surgery and their fusion. And I'm not going to go into the details of the ethics of that at the moment, but basically you just need to be aware that you need to be counseling them to stop smoking to give them the best result. You need to take a full medical history. You need to talk about the medications that they're on. You need to know if they're on steroids or any disease-modifying anti-rheumatic drugs. And particularly steroids can affect skin healing. And anti-TNF medication, you may need to stop it because, again, a lot of these patients who need these fusions have rheumatoid arthritis. So again, just general principles when assessing patients for surgery. So it's really important with fusion surgery to plan your incisions, particularly if you need multiple incisions, to make sure you have a wide enough skin bridge, make sure they're long enough, and make sure you avoid tension on your skin edges. I think it's really important to use your image intensifier right from the beginning. It can be really useful to help plan your incisions, but also it can help you to identify the joint with a needle so that you know that you're fusing the right joint. And that's, I think, an important thing to do, particularly in the early stages of your career. And I still use it to this day. You want to create very broad and congruent cancellous surfaces that can be placed into easy opposition. And the reason that's important is that if you prepare a joint surface and it's not completely flat, the surfaces won't sit together and they'll come off each other. And I'm sure if you've done an MTP joint fusion in a man who's very sclerotic and you haven't got your surfaces completely congruent, the bones can just rock on each other. So you need to have really nice opposed surfaces so that the fusion sits together nicely. Again, when you're talking about alignment in the foot, whatever surgery fusion you do, you need to make sure that the foot is aligned to the lower limb. And the best way to do that is to have the patient supine, you have the patella facing the ceiling, and the forefoot needs to be aligned to the hindfoot. And you need to always correct any proximal, very severe deformity first before you start affecting the foot. So you just need to be mindful if you're deformity correcting, what position your leg is lying in and how you're aligning all of the joints more distally. So joint preparation, I mean, obviously what position you put the joints in is extremely important, but I would say that joint preparation is really the most essential part of any fusion. You need to be able to create these really roughened cancellous surfaces that will allow bony fusion to occur. And it's really important just to take off the cartilage, avoid resecting too much bone or that will affect your position. As I've talked about before, you need to really make sure you get down to the bottom of that joint, and you can use a laminar spreader or a Hinchman retractor to get deep into those joints. Some of them are harder to get into than others, and again, with time and experience, you begin to learn that. You need to get down to that soft, gooey, yellow cancellous bone, and you can use the drill to pepper pot the surfaces here, and then you can petalize them with a small osteotome as well in the bigger joints. You can use big K-wires to hold the joints while you're planning your metalwork fixation. And again, particularly in the midfoot where union rates can be challenging at times, it can be worth considering tibial graft for the proximal tibia or even iliac crest graft, depending on your patient. This picture here is just like from that Lapidus picture where you see how deep and long the first tarsometatarsal joint is here. So that was just to drive home that point, but I've already said it. So there we go. Okay, so now joint preparation is key, positioning is key. And you're probably thinking, oh, what kind of fixation am I going to use? And at the end of the day, you need rigid internal fixation, which is going to be a combination of compression screws, locking plates, and maybe even staples. Ultimately, there are so many options for what you can choose to do for your fusion. So to me in this talk, it's kind of beyond the scope to talk about all the different ways you can fix things, but ultimately you just need to know that you need to maintain your compression across the joint while you're fixing and then augment possibly with a plate over it. You want to make sure that your screw threads, if you're using partially threaded screws, actually go across the fusion site for maximum compression. And basically with all metal work that you put in, you just need to be thinking about where you put it, if it's very prominent, if the screw heads are in the heel, if the plates are just under the skin. You just need to advise the patient that they may need to have those removed at a later date. And most fusion patients will end up in a plaster, usually for 6 weeks, usually non-weight bearing, and go into a boot at 6 weeks. And again, it will depend on the type of fusion, how you do it, but on the whole, you're giving some additional stability with the plaster. So going back quickly to the midfoot, I think the key thing in the midfoot is basically do only what you need to do. Don't do any more and don't do any less, and don't just fuse joints for the sake of it. You really want to be just fusing the joints that are painful, that you've had that positive result from the injection, and combined with their clinical picture. As we talked about, you can do the in situ fusion if there's no deformity, and consider your bone graft as union rates. You can have about up to a sort of a 10% non-union rate. We talked about the screw plate fixation there in compression. So just a quick note on skin incisions here. So again, when you're planning in the midfoot, depending on how many joints you need to deal with, that's sort of a standard approach for getting into 1 and 2. But if you need to maybe think about doing your first tarsometatarsal joint arthrodesis and then actually doing 2 and 3 as well, you may want to consider 2 incisions with an adequate skin bridge here. And with time and experience, you can figure out how you want to attack your joints. And again, some of this applies to Lisfranc fracture fixation as well. So it's just to drive home the point that you need to plan your incisions and have your skin bridges wide enough. The lateral column, 4th and 5th TMT joints, they're very mobile. It's not really recommended that you fuse them. You want to consider an excision arthroplasty, and you want to maintain mobility, just like you've all learned for Lisfranc fracture fixation. And again, with these, I would just say activity modification, shoes, and inject them, and really avoid surgical treatment unless necessary. It's not a very common problem that needs surgical treatment. So complications of fusions, so there can always be problems with wound healing, infection, metatarsalgia if you elevate those rays, damage to nerves and vessels. Again, when you're approaching the midfoot, you have some pretty key clockwork there between the first and second metatarsal. And again, the superficial nerves on the foot can get injured. And non-union is really the big one. So it's up to 10%. And neuroma formation can occur too with that neurovascular injury. We've talked about the need for removal of metalwork. And again, I think you have to counsel patients, but to me, that's in the overall sort of holistic discussion about their treatment. They just need to be prepared that in their lifetime, they could develop arthritis in adjacent joints. So just a very quick case. So this was a 63-year-old lady who I saw in clinic, and she was quite an active lady. She cared for her father who was unwell. I think she worked in an office, nothing too strenuous, but over time she developed pain in that midfoot. And interestingly, she had pain with palpation over her second and third tarsometatarsal joint, and also over that medial navicular cuneiform. So we ended up counseling her. I would have to be very clear in my mind, because the reason I remember her is that I had a bit of a debate about how much pain she had in that medial navicular cuneiform, but she really did have point tenderness there. So we went ahead and we actually fused her second and third tarsometatarsal joint and also that medial navicular cuneiform in one go. And I'm very happy that she's united. We did put some tibial bone graft in there, and it was quite a big fusion mass in the end. But I think this case drives home to me why you really don't want to be adding in joints that you're not quite sure about. You have to be pretty convinced that they are contributing to the problem. And if you can exclude joint pain through injections and clinical examination, that's definitely worth doing. But when it's needed to be done, you do the joints that need to be done, no less and no more. So the metal work here with the tarsometatarsal joints, I don't tend to put a screw across the joint because there isn't room. You can just bridge them with locking plates, but you've maintained the position with K-wires. You're putting your manual compression through the joints and putting the locking plates on, and then you're adding bone graft in there as well to help them fuse, okay? So that was a tour of the midfoot, and we're just gonna talk a little bit more, probably for about another 10 minutes, just on hindfoot arthritis and some of the key points to bring out which are relevant there for your learning. So we've talked about the hindfoot essentially being the triple joint, okay? So it's subtalar, talonavicular, and calcaneocuboid. The subtalar joint has the three facets, posterior, middle, and anterior. And the talonavicular joint, you have to remember, is like a ball and socket joint. It's a very big, deep, wide joint. So when you're preparing to fuse it, you need to be mindful of its anatomy and that you clear all the different surfaces. When talking about hindfoot and how we treat arthritis and fusion type surgery, it's worth thinking about what the physiological alignment of the foot is. So essentially, when you're looking at an AP radiograph, and we'll look at the lateral, you essentially want good alignment of the talus with the first metatarsal, okay? So here, before, so this person's had some sort of triple fusion, the talus is pointing medially here, so there is no alignment. But when they've had the fusion, the talus is then pointing in the same direction as the first metatarsal. And the same is true here in the lateral plane, that the talus is pointing down prior to correction in this flat foot deformity with this talonavicular break. And then it's not lining up with the first metatarsal, but after things have been corrected and the joints have been fused, that alignment is there. So ultimately, when you're aiming to create that plantigrade stable foot, you're aiming to have that alignment of the talus with the first metatarsal in both planes. So the other thing that's important to remember about your triple joint is it's three different joints, but essentially it works together to allow for inversion and eversion. And it allows you to walk on uneven ground. And whether the joint is fused or it's very stiff, because it's arthritic, it will limit the ability of the other joints to perform their function. So they're all intimately linked together. The hindfoot's important because the transverse tarsal joint, which is your talonavicular and calcaneocuboid joint, are active during heel strike and heel rise. And during heel strike, the transverse tarsal joint is unlocked and it acts as a shock absorber so that the force can be distributed through the foot. But when the heel rises again, those joints lock and it becomes a rigid lever for push off. And that's really important for normal gait. So when we talk about fusing the joints in the hindfoot, it seems fairly straightforward to say that if you have isolated subtalar joint pathology, you're going to do an isolated subtalar joint fusion. If you have an isolated talonavicular pathology, you're going to do an isolated talonavicular fusion. There's a couple of little caveats here, which we're going to talk about how you can add different joints in to create a more stable joint that will have better function for the patient. If you have very severe deformity in the hindfoot, you can consider something called a triple fusion, which is a subtalar joint fusion, talonavicular, and calcaneocuboid, and can be used to correct many types of deformity. And at the end of the talk, we're going to talk about that in more detail. So it's just important to remember that's the final thing that you can think about. But we're going to talk about the different isolated joint fusions and how they relate to each other. So again, just like in the midfoot, you're going to fuse the appropriate joints based on what symptoms the patient has, what their imaging shows, and what the response to treatment is. You have to be very aware, particularly in the hindfoot, about this risk of contiguous joint arthritis. And the most important thing to remember, and I love this like fun fact about hindfoot arthritis, that if you fuse one joint of the triple joint, it will significantly limit the motion in the other two joints. So you're essentially rendering them very stiff. And the talonavicular joint, arthrodesis, results in the loss of 90% of that subtalar joint and calcaneocuboid joint motion. So it's almost like fusing all of the joints when you just do talonavicular joint arthritis. The subtalar joint is a little bit more forgiving. It limits the talonavicular joint motion by about 70%, but that will have an impact as you rely on that transverse tarsal joint to mobilize during gait. So we'll talk about the individual joint arthritises quickly, and then we'll talk about the triple fusion. So the most common cause of subtalar joint arthritis is going to be post-traumatic after a calcaneal fracture, but it's quite common in rheumatoid arthritis, and you can just get osteoarthritis. The other fun ones for subtalar joint arthritis are old talocalcaneal coalitions that can't be resected, and you often fuse subtalar joints related to cava varus foot deformity, in the old days poliomyelitis. So patients are very clear with subtalar joint arthritis that they have pain walking on uneven ground, and they will often gesture to the lateral side of the ankle and the sinus tarsi when they're localizing pain. It's really important to isolate your subtalar joint in clinical examination by holding the talar neck and head and inverting and everting the foot underneath to elicit that pain. Again, straightforward orthopedic principles. You treat with orthotics, activity modification, orthosis to minimize motion, and then you can do diagnostic and therapeutic injections. If you get to a point that you want to fuse the subtalar joint for them, of all the hindfoot joints, it's the one that patients really have the best chance of achieving a high level of function. So it's a reasonable one to offer in isolation. Surgery can be done either arthroscopically or open. Most people perform the surgery open, and they use a utility lateral incision, which is basically from the tip of the fibula to the fourth metatarsal base. And you need to be preparing that posterior facet and the middle facet, and then fixing it with 2 screws from the calcaneum into the talus. The most important thing to remember about the subtalar joint fusion is that you mustn't put the subtalar joint into varus when you fuse it, as it will lock the transverse tarsal joint, and the patient will be very unhappy. So it's really important to fuse it in about 5 degrees of valgus. So talonavicular joint arthritis, it's seen most commonly related to inflammatory arthritis, rheumatoid arthritis, but can obviously be post-traumatic. I see in Coventry, we're a trauma center, and I see an awful lot of talonavicular joint trauma for whatever reason. So that can be a problem, or it can be a degenerative part of tib post dysfunction. Again, we've talked about the loss of motion to the subtalar and calcaneocuboid joints if you fuse it. But if you need to fuse the talonavicular joint because it's painful, you need to do it. You just need to be aware of the impact it's going to have. The one that I think is interesting too, and I saw a couple when I was in my first couple of years as a consultant, is when you've had avascular necrosis of the navicular, you can get a really bad talonavicular joint arthritis that you have to fuse. But because that navicular is so sclerotic and shrunken down, you need to actually bridge it and fuse into the naviculo-cuneiform joints as well. So again, you just look at the pathology that's presented to you and then use your principles of arthrodesis, and you fuse the joints that need fusing, and not any more or any less. So talonavicular joint fusion, you can use different incisions that are described in the books, but the one I find most useful is sort of a dorsomedial incision. So you're going, it's the extension of the anterior approach of the ankle between tib-ant and EHL, and you can really see the top of the talonavicular and get around the sides, but you can also go medially through tib-ant and tib-post, but again, you may not see that lateral side so well, so you just need to be mindful of the shape of the talonavicular joint and make sure that you get down and see all the surfaces. You need to preserve the shape of the talus, and again, really get down to the bottom of the joint, and your joint position is really critical here. You need to make sure that it's lined up nicely to enable the other joints to move as much as they can. They report good union rates of only sort of 5 to 10% non-union rates. But I think, again, because of the poor access and the avascularity of the navicular, you need to be aware of what you're doing so that you have the optimum chance of having good union rates. So finally, the last thing to talk about is what is a triple arthrodesis. So we've talked about restoring the alignment to the hindfoot, lining up that talus with the first metatarsal, and over time, in the hindfoot, if there's pathology such as pes planus, midfoot arthritis, cavus, the alignment of the hindfoot can be distorted by the dynamic stabilizers, the tib post tendons, the peroneal tendons, and with time, the ligamentous restraints weaken, and you see those classic deformities, whether they be cavus, planus, related to inflammatory arthritis or post-traumatic. And essentially, the triple fusion, because you're attacking all three joints for fusion, it can be used to treat any sort of deformity because it's a corrective fusion, and you can align the joints to make your stable plantigrade foot. And you're essentially aiming to restore good ankle motion to 90 degrees, having the hind foot in that 5 degrees of valgus, and then the forefoot in the neutral and plantigrade position. So again, I'm not going to go through the major technical details here, but it's worth just understanding that, again, you're going to plan your incision, you're going to have your utility lateral to get to the subtalar, and then your calcaneo cuboid, and then your dorsomedial approach to get to the talonavicular joint on the other side. But again, the talonavicular in this approach, you can see it from both sides. You always need to assess your tendoachilles and gastroc to make sure there's no contracture. And it's important to, again, align your joints in the right position, and you can reduce the talonavicular joint first, then your subtalar, but you need to really make sure that the calcaneus is centered on the talus and make sure there's no varus. In very severe deformity, it's quite an interesting cadaveric study to look at. If you have a very flat pes planus foot, you might think, well, if I make a big lateral incision, when I bring that heel around, I'm not going to be able to close the skin. And if that's the case, you can actually do, you can approach the subtalar joint from the medial side, centered around the sustentaculum tali, and it's actually quite a nice view of the subtalar joint if you need to do that. So here are some post-op films of the triple arthrodesis. So you have your subtalar joint fusion, talonavicular and calcaneo cuboid, and it's a big operation. It's not something you do regularly, but basically patients are generally very happy with it. And I think the reason for that is they've had such a deformed foot that's affected their gait that they're happy that although the foot is stiff, it's pain-free and they can get back to doing some of the activities that they like to do. So in conclusion, that was a lot of information. Basically, if you remember nothing about this, anything to do with midfoot or hindfoot arthritis, you always want to do your conservative treatment before you do surgery, and only do surgery as a last resort if the patients are significantly disabled, because they're always going to be at risk for non-union. It's really important to take a very careful history about what joints are painful, very clearly document your examination, and combine all of that information with your imaging so that you target the right joints for your injection and eventually your fusions. It's so important that patients understand that these operations are a big deal. You need to manage patient expectations regarding stiffness in the foot and potential for future arthritis, and how that's going to affect them. And again, if you learn nothing else from this talk, when you prepare your joints for fusion, you need to make those joint surfaces really cancellous, soft, roughened up, and it should look like a dog's dinner. That was the phrase that my consultant trainer on my fellowship used to say. And you literally want to just break all those joints down, the sound surfaces down to cancellous bone, drill into them, pedalize them, and when it looks a complete mess, you've done enough work. And then obviously position is really important, but again, preparation of surfaces is really good. There's a few useful papers there. I mean, I think this is all being recorded, so you can have a look at those. There was a couple of good reviews looking at midfoot arthritis, and then there's a nice paper here about efficacy of foot and ankle steroid injections that just gives evidence for what we do, because you spend a lot of time injecting feet, particularly mid-feet, when you're a foot and ankle surgeon. Okay, so I think we're going to move on to a discussion now. This is sunny Coventry, the two cathedrals, and that's the hospital where I spend a lot of my time. Good, thank you very much for listening. I know it's late in the evening.